because I realize I need to be more mindful when I'm teaching you guys. There are things I do intuitively that are intuitive to me, but I need to go through every little detail with you guys. One of those things is from the minute I'm talking to a patient or getting ready to start working on them, I'm feeling their body.
Welcome to the Dr. J.J. Thomas Podcast.
Welcome to the Dr. J.J. Thomas Podcast. I'm J.J. Thomas. I want to first thank all of you guys, because really this is why we're doing this. Like me coming in every week and sharing, what I hope is helpful knowledge for you. What it's really about is you guys and the interactions I've been receiving from you, the messages, the exchanges, really just, it means so much to me. So first of all, thank you for being amazing clinicians, amazing people, and in general, just people that just want to do better in the world. So thank you. On that note, this episode that we're offering for you this week is in response to that. I always get great feedback from you guys on how you really enjoy seeing live footage from our Dry Needling Masterclasses. In it, as you know, we share techniques, we share information on how to dose needling with your patients, certain clinical scenarios. So with that, we're going to share our most recent Dry Needling Masterclass with you, and that's the beauty of it. Every class is different because every class is live and in response to those participants' needs at that moment. It really is an environment meant to teach people in an intimate setting and really give you exactly what you want. So hopefully this episode speaks to you. If there's something else you'd like to learn, either drop me a DM, leave a comment below, or sign up for a masterclass. See you soon. You guys are here after a long day, really. Yeah, I know. It means a lot. And it's cool because last night my daughter, most of you know I have a daughter at Virginia Tech, and she called yesterday. She had her last exam before she was driving home. She was a little stressed out about it, and she's like, Mom, I'm just putting so much work into this stuff, and and she's like, I don't know if it's paying off. I'm like, it's paying off. Like the work is the reward. We forget, I think, and as I was saying this, I was thinking of my own journey of learning, and when I'm teaching therapists, anything from movement to dry needling, it's like the work is the reward. Like you put the work in whatever you're learning, and you cannot help but be better. Like it's really just the time, right? So thank you for taking the time to come and be better.
Of course.
Yeah. And so the other cool thing about what I really love about this is, you guys, most of you came to one of my earlier masterclasses where I had a slideshow, and that's again why I've kind of gotten away from that, because I realized what I really want it to be about is whatever you guys need. Truly the origin of this masterclass it is exactly what I wish I had when I was a new needler, because I had questions and I would call my friends and talk through it with them on the phone, but it's not anything like having an expert in person with you to watch you and give you comfort that you're doing it right or that you need to do it differently. So I wanted to start today just by what questions might you have? Are there muscles or muscle groups you want to make sure we get in? Let's just we have 2 hours, so let's just get into the meat of what you want to do today. Everybody knows each other? Should we do a quick intro?
I'm Tara.
Yeah.
I don't know if I met you guys.
I can't remember, I know, I can't remember who.
You were here before, right? Okay.
Let's do quick intro. I'm JJ. Abby.
Hi, Abby.
And Abby, what setting do you work in?
Outpatient orthopedics.
Yeah, Abby's in North Wilmington, right? At Elite. Yeah. Yeah. That part won't go on. Don't worry, that won't go. At Elite PT, and you treat general ortho mostly, right?
I do, but I'm moving into pelvic health.
Okay, great. Oh, I have the best pelvic floor muscle for you.
Okay.
Yeah. Access. I might have showed you. I showed you in the primal integration, but I'll show you again.
Yeah.
Kevin, you're at.
I'm Kevin.
I know.
Hi again, Kevin.
And you also are still doing are you still doing the work on the side?
Yeah, my last day leads tomorrow.
Wow, congratulations.
Thank you.
That's really cool.
Picked up a per diem job so I can work 20 hours and then scale the cash back.
Let's go. That's awesome.
Thank you.
And recently married, by the way.
A month ago.
Yeah, very cool. Very cool. Jess?
I'm Jessica. Nice to meet you. I don't know. I never met all you guys, but I work here.
And Jess treats everything right now too. Yeah.
I'm
Tara?
I also work in outpatient orthopedics, new needler, but I'm gonna work at Primal's new location in King.
Yeah.
That happened, so
Yeah.
January.
It's very cool. It's very cool. So cool. All right. So yeah, what does everybody, now that everybody remembers names and everything, what, Abby, is there anything specific you want to learn or go over?
I would like to review cervical.
Perfect.
Yes.
And what specifically is giving you, like, is the multifidi in the cervical region kind of scary?
Yes.
Yeah.
And then also like suboccipitals, like delineation of which ones you're really working on.
And do you mean suboccipitals or do you mean erector spinae on the occiput?
Probably both.
Yeah, I mean, so technically, like, I do needle suboccipitals, but it is more of an advanced skill, and I'm happy to help you guys with the differences, but it's important to know if you're needling erector spinae at the superior nuchal line, or if you're needling suboccipitals on closer to the inferior nuchal line, because there's a big difference in terms of level of difficulty, essentially. Cool. Anything else? Pelvic floor, probably anything.
Anything pelvic floor.
Yeah, okay, sounds good.
Like hip, low back, pelvic floor.
Got you.
Anything in that world.
Got you. Yeah. Kevin, what about you?
Medial forearm, like wrist flexors.
Great.
I just don't do enough of it. I feel like I get too much vascular symptoms with people just 'cause-
Yeah.
Yeah.
And is that for, like, specifically for people with medial epicondylitis?
Typically.
Yeah, because I think I might have some advice, some clinical advice on other things that might be more helpful even than doing the forearm.
Okay.
So we'll talk about that too.
Okay.
Cool.
And we haven't learned hand because we're not being free from pain yet,
Perfect.
but it'd be good.
Hand is money, especially thumbs are great. Yeah, great. Okay. Jessica.
Yes, I was also gonna say the same as you, the erector spinae, just on the occiput.
Okay.
I'd really like to review that.
Great.
And lower traps seem like something I've been really wanting to get into.
Lower traps are money.
Yes.
They're great.
And
They're great.
I have patients that really need it. And
Yeah.
don't feel comfortable. And there was one more slipping my mind. Oh my god.
It'll probably come to you.
It'll come to
That's
me.
okay. Let me
That
know
was
when
the
it
big
does.
one. The glute. Yeah.
The one,
you were doing.
it's so good.
Yes.
I actually, did you see me doing it on Holly the other day?
Yes.
Yeah.
I need that one.
I started needling my own glutes. That's how I discovered all these new ways. I'm not kidding. Because I was like, and I was like, how? I was like trying to get it, and I was like, I can get it like this. So I'm like this, and then I'm like, and then the one day I was like, am I like this? I'm like here. I'm like, I got it. So yeah, I'm gonna share all these things with you guys. All right, Tara, what do you?
That's what I was gonna say, like the quadratus femoris, like in the back.
It's
the deeper hip muscle.
So we'll do that whole series. And I'll say, like, since I've discovered this other way of accessing them, I don't have to do as many series of glute med min on patients. What I discovered is that it's sort of in my mind like, I don't know, I think I should just back off from that. But when you activate the lower gluteals, these guys are settling, is my point. Like, I think I've been unintentionally chasing symptoms, not symptoms, but muscles that are overworked by treating a lot of glute med min. Not that you don't need to treat them, but I find when these guys need it and you treat them first, these guys stay settled, and you're not, because that's why I started searching for this, because even on myself, I was doing these guys and I was doing them a lot, and I'm like, why is this not better? And that's when I started like, and it's all kicking in, and same thing with our patients. So we'll talk about all those things. Any other?
Like at one of our mentorship days, you were talking about like the little triangle up here for the tricep.
Yeah.
To get to the elbow.
Yeah, so radial nerve comes out of the triangular space, or I think it's technically triangular interval, but we'll go over it. And then there's another piece on the tricep that feeds the ulnar, that entraps the ulnar nerve, which is, I think, probably what your medial elbow people need. So yeah, we'll go over it. That'll be perfect. Let me think about how. So we'll start at the neck. We'll do neck review, and then we'll go from neck. So we'll do that, and then we'll do arm. We'll do both your goals at the same time. So we'll do radial nerve, and then next segment will be kind of ulnar nerve flexors. and then we'll go into glutes, and then we'll see what else we have time for. Is that everything? Did I hit everything? Oh yeah, low trap we'll do low trap with the arm. Great. All right, let's do it. Usually I do help you guys with assessment, but I think since it's 2 hours and you guys are here for needling, I'm not gonna do a lot of test-retest, just because I want you guys to get the needling practice. So just real quick, just feet together, just look down and up, and then center, and then look right and look left. Not too bad, right is more limited than left. Open your mouth, close, go face down. Right was like slightly limited, that's all I saw, but also just wanted to do that just to make sure nothing glared, like if I don't wanna like do something that aggravates her either, so we'll do a quick screen on everybody. Lift up real quick, Jess. And what do you have? I would love to see some more skin here. Can I see some more skin? I think so. I want people to like, because we're going to go over multifidi. You want to go over multifidi too, right, on the neck? Yeah, okay. Yeah, thanks, Jess. This is a weird little thing that I'm going to tell you guys, but make sure that your patients, if you have a face hole, make sure they're whole. They need 3 points of contact. If they don't have 3 points of contact, they don't know where to put their head, and they'll be doing all this. So Jess, are you comfortable there?
Yes.
She has good 3 points of contact. I'm going to fix your hair so we can see your neck better. Well, I'm going to unfix your hair, actually. And I'm going to just slide this down. So we'll start with multifidi, and I am actually going to come on the other side. If you'll notice, here's another little weird analogy for you. I've been making sourdough, and I really sucked the first like 5 or 6 times, like really bad. Like so bad that I sent one of my chef guys a picture, and he was like, is it even cooked? And, but I realized, he was like, let me send you my recipe. So he sent me his recipe, and I realized one of the things that I read my instructions said to, they call it scoring or laming the top, right? And I was like jamming this thing in, and his recipe said like, you wanna hold it at a 45-degree angle. Like there's little details all the time that are really important. So it relates to us here because I realize I need to be more mindful when I'm teaching you guys. There are things I do intuitively that are intuitive to me, but I need to go through every little detail with you guys. One of those things is from the minute I'm talking to a patient or getting ready to start working on them, I'm feeling their body. Like immediately as I was talking to you guys, I'm already feeling her neck to start getting to know it better. You know what I mean? So that's something that's subtle, but I think really important, kind of like scoring the top of the sourdough bread, that if you can just spend more time palpating your patients before you go to stick a needle in, your brain will have already kind of mapped out what you think you're feeling better, okay? So just a little side note there. I usually do the neck from the other side, and I'll show you why. So I'm gonna come on this side real quick. So we're gonna start with multifidi, and then we'll go up and I'll talk you through the difference between suboccipitals and spinal erectors on the occiput. I just did a little thing too for YouTube on like efficiency of needling, and I was mentioning how like before you even palpate to stick the needle in, get your area ready first. Like it saves you probably 5 minutes. So I felt her a little bit, but not with the intention of like I didn't set my fingers up yet because I want to have everything clean and ready, including having my needle ready before I even go to do anything. So this is a 50, which is what I want. So now I'm all set. So the way I like to needle the multifidi, first of all, orient yourself, find C2, okay? What level you took? Level 1 myopain, level 2, I forget.
1 and 2.
1 and 2, great. So C2 is here, and I know that because first of all, it's the most prominent, and then when I go from like C2 up, I'm like butting up against the occiput, right? So that's C2, so that's perfect. And then just kind of orient yourself. I feel the next level, the next spinous process is C3. Jess is a little jammed up in C3 and C4. But one thing that I want you to take notice of, again, before you go to stick your needle in, is what angle is her neck at each level, right? If I'm palpating and I think based on her motion that she's tight at say C3, if you look at her angle of her neck, she kind of divvies in at C3. And if I use my fingers to draw a line across, that perpendicular angle is pretty like A to P in terms of craniocaudal, right? But if I come down to like C7 on her, probably C6 that is, and I draw a line, that angle is very different. It's more caudal than or PA, I guess I want to say, right? So now I'm going to show you guys, I probably showed you this trick before, but I loved this trick when I was a newer needler because I didn't have any master classes available to me. I would take a needle and throw it out and then use that tube. So this is a 30 because her neck is kind of small, and then lay the tube along her spine and press it down on both sides so you can see the angle at different levels. Because remember, an effective multifidi approach is going to be, I never cared for the term like inferomedial. Like you really want to be perpendicular to the lamina. So you have to know how the lamina are lying. So at this level, the lamina are going to lie like this. At this level, the lamina are going to lie like this. See the difference? So your patients don't know that it's not standard for you to take an empty tube and put it on them. So don't stress about that. Like, it's better to just get the reps in. I obviously don't take an empty tube anymore. But when I was first needling, I did, because I was like, this would help me visualize my approach in a way that was safe and effective. And now I don't need to use the tube to visualize because I've built those reps up. The work is the reward kind of thing, right? So now that I know where that angle is, I use one finger. If I'm doing the left side, I use my pointer finger on the spinous process. I pull the tissue away to get a blanched line. See her blanched line there? And I can kind of feel where the presence of that articular pillar is on the left. If you're not sure, just keep it about a finger breadth away, okay? Or you can also kind of go where you feel the muscle bulk end a little. But it's not a huge line, right? This finger is constantly on SP, so I am oriented to where my needle is in space. Then I'm going to put this tube in between that blanched line, compress the tube, tap DIP hard, and then I'm just going to angle this to where I know the lamina is because my fingers told me they are. There it is, boom. So as with everything I say, like measure twice, cut once, meaning you spend a lot of time palpating and feeling and getting oriented to where your tissue is, and then when you go to put the needle in, it's literally no big deal. But if you haven't done the setup, then you're going to spend time like, am I in the right spot? I don't know. Maybe I should pull it out. Maybe I should do it again. You end up being much less efficient if you don't, on the front end, just take the time to really assess, right? So let's do the right side. So same kind of thing. I'm going to get my needle ready. And I'm going to use a 50 again. Jess, you good? So if I want to do, let's do a different level. Just so So I'm going to come below where I was because see how that angle is going to be different now. See how that perpendicular angle is now slightly more caudal, if you will, right? If I go exactly perpendicular, so from a north-south perpendicular and from an east-west perpendicular to that blanched line, that's what our goal is. Can you guys see that? See the blanched line?
Yeah.
So perpendicular is going to be just like that.
Okay.
Compress, tap, and you literally just go right. A little stiff there, girl. You good? And there's lamina. That one was tight. And that's the other cool thing. Like when you know you've set up completely effectively, when you hit that tissue that's a little bit like feels not right, like you're like, no, you can immediately feel your fingers are in the right spot and you don't have to worry. Whereas if you haven't taken the time to set up and you feel some resistance that that likely the resistance is just a muscle that needs to be treated. But if you haven't taken the time to make sure that you're on point with what you're palpating, then you're going to hesitate again and you're going to be less effective, right? Yeah. So the other technique here, so we'll do these first, then we'll practice, then we'll do the erectors and the subucs. But the other, you can also practice the wraparound technique, which is great for the lower. I find the wraparound technique great for the lower, like these vertebrae, because it's easier to palpate. So like, the wraparound technique is going to be, Jess, can you actually put your arms? So remember from our other courses, like position is huge. So I mentioned the 3 points of contact on the face are important. The other thing that's really important, I should have mentioned this sooner to you guys, when patients get on the table, especially at the neck, they're so nervous that you're gonna, like even patients that are very laid back and cool are nervous about getting the neck needled, right? I'm sure when you guys took your courses, you were nervous about even your therapist who knows the body needling your neck, right? And that's with good reason, because if they're super flexed, then they are gonna potentially open up that nerve root way more easily than in like even the lumbar spine. So, but the problem there is when patients are nervous, they want you to feel and they like chin tuck and do this because they're like, oh, I want her to feel everything she can, but then they've just exposed potentially their nerve roots more. So before you stick a needle in them, make sure, I always like feel their head and make sure they're in, you want them in neutral or even maybe slight extension, but more, you know, obviously neutral is ideal. And if you're not sure, I usually just like lift them up and then just let them know like that's where I want your head, because otherwise they'll keep doing this, okay? So she's in a good position. 2 fingers on the spinous process. Whenever I used to struggle with this, like, because you know, you feel these spinous processes and when they're all like jammed up, sometimes you're like, what am I on? Like, where does this spinous process start and where does it end? Yeah. So one of the things I do intuitively, like the scoring of the sourdough bread, is just like kind of combing up and down. And I can feel with 2 fingers, I can feel when my bottom finger hits the bottom of that SP and when my top finger hits the top of that SP. And then just settle in, slide, 1 finger breath off, compress, spread. And then again, you can see on that blanched line, the sharpness of that angle is very different than you might expect. But because we already laid that tube there, we knew that it was gonna be at that angle, right? And then my fingers confirm that. So I'm on 2 fingers on SP, I come up, down, I settle in, I come 1 finger breath off, I compress and spread, I see my blanched line, I compress the tube, I DIP tap, and then I'm gonna go right into multifidi. Yeah, rest your arm so that you have more stability when you go to put it in, okay? Any questions? Good, good. All right, let's give it a try. Jess, good job.
Thank you.
C2, occiput, C2, occiput, and then just get oriented, C2, C3 is kind of diving down there, C4, C5, so she, you know, everyone's a little jammed, honestly, 4, 5, but just kind of, and then what I was showing them with the tube, I'll kill a new tube, so I'm not using the same tube on different skins. So I don't know if you've tried that yet, Jess, but like just literally taking the tube next to the spine, and you can it makes the perpendicular angle so easy to see. And then you can see how here, if I was to do like T1 on her, that angle is very different. Yeah. Make sense? Yeah. It helps a ton. Yeah. So just a little tricker there. So SP, take the finger, pull it apart, and then split the difference. I see my blanched line. I want to be perpendicular to that blanched line from a north, south, and east, west direction. And then just a single, boom, there's SP. That's it. Beautiful. I mean, SP, that's lamina, sorry. That's lamina. That's it. And then the other way, when I do the other side, are you guys okay over there? On the other side, I do middle finger. I'll go 1 low, 1 below. Middle finger, blanched line. Split the difference, compress the tube, DIP tap. Perpendicular. Oh my God, you're really rotated there, Tara. Holy crap. Hold on 1 sec.
Help me.
Oh my God. Help me. SOS. Wow. There we go. So I just came out a little farther because I think because she's rotated, I actually got a piece of her SP a little bit on that first one. There. I'm way out on her articular pillar there. And you can almost comb, just like we do in the lumbar spine, to comb across to get iliopsoas. I'm actually combing along lamina here to get all the erector spinae that are tight on her. You see what I mean? Like I'm still on articular pillar on her. Crazy. All right, cool. Make sense? And then the wraparound technique, you know.
I love that.
Yeah,
That's
okay.
what I haven't.
That's what
used
you
that
usually do. Yeah, cool. Great.
Sounds good.
Sorry, Dane. Perfect. Yep, come a little closer. There you go. That looks perfect.
Cool. And my index finger's right on.
Yep, I can see it. It looks amazing. So you just split that blanched line, like, and then press this one. Yeah, and then you're going to end up perpendicular from a north-south and an east-west perspective. And you're going to compress that tube. So perpendicular would be like that. So press that tube really tight into the skin. Press it, like let the needle drop down and press the tube down hard. There, now DIP tap hard. Yes, now put that in your hand. Grab that needle before it touches your glove. Redirect it to the right angle. Nope, angle will be like that.
Oh, like right there?
Yeah.
It looks.
It's not
more
wrong. You just
superior.
tapped it a little bit in closer to your finger than like, see how, like I would like you to split the distance between these two. I
So
feel like
tap
you're
it in a
too
little bit
midline.
outside.
Yeah, well, tap it literally, if your line is like this,
Yeah.
tap it halfway between point A and point B.
Okay.
So I would redo that one. It's not dangerous, but you're gonna end up butting up against SP a little bit.
Do you go individual?
I
or
do.
sheath? Okay.
I just don't feel like it's worth it. Like my patients, it's a 8 cents investment, 10-cent investment. I just feel like my patients are worth 10 cents to get a new damn needle. I don't understand.
These all 30s?
Oh, so they're in boxes. Like these are 30s, 40, 50, 60.
Okay.
See?
Okay. Because there was a 50 in here.
Oh, that might be somebody, probably me. Some dumbass put it in the wrong thing. We do have singles there too if you end up, but.
That at least works for right now.
It's definitely easier to feel. When you're still developing your 3D orientation of the spine, it's easier to feel with the wraparound. But there'll be times when once you get that down better with reps, you're faster with this one, to be honest. And that's perfect. So what I'm saying is don't go closer than halfway through that. Go, in the middle, or you could even start in the middle. And then you could comb. That's a perfect angle. Now compress that tube, let the needle drop, compress the tube, tap hard. Grab that needle quickly, then just continue on that path, that angle that you just started.
Okay.
Looks beautiful. I think you're gonna get there very soon.
Yeah.
Yeah, you're almost there.
Yep.
Are you there?
Yep.
Great. Yeah, it's perfect.
Okay.
How'd that feel?
Good. It's definitely more of a superior orientation.
It's not superior in the slightest bit.
Right, but like when you learn it in the class, they're
That's what I'm
always
saying.
telling you that.
But that's the problem is
So
that
it looks it,
you're,
even
but
though
you're
it's not.
actually, you're not building your, because I used to be in those classes where we would teach inferior medial, right?
Yeah.
But the problem is you really don't want to be inferior medial because that doesn't give you three-dimensional perspective of where the heck you are every time.
Mm-hmm.
What you want to be is perpendicular to the lamina every time. So if you every time orient yourself to where that lamina is, and then you go perpendicular to the lamina, you'll always be right.
Mm-hmm.
But because the problem when you're here and you just are sort of guessing inferior medial, like, first of all, what I really don't like about that is that if you're on this level, and then all of a sudden you're inferior medial, and the rib is coming up here, you may overshoot and it's not safe. So the safest way is to hit lamina every time. And the only way to do that is to palpate in a way that will teach you where lamina is every time. So yeah, you weren't superior at all. You were just not inferior, but you don't need to be inferior. They only would say that because they didn't want you to go superior because they didn't want you to hit the nerve root that was coming out superior. But if you palpate accurately, you're not going superior, you're going perpendicular to the lamina. So you're good. It was perfect.
Okay.
Good.
Sweet.
Do you want to try this one? Because that side's a little different. And you could do it on the other side, but I prefer to just switch I will do a second, middle finger on SP and then pointer finger blanches.
Okay.
So I'll switch it now. Yeah, so middle finger on SP.
I went like one
There you go,
below
yeah. And then use that finger to blanch. Beautiful. And then, excuse me. And then you're gonna perpendicular. Now, did you move this off SP? There you go. Yeah, keep that on SP so that when you second guess yourself, you know where SP is. There you go, that's perfect.
Okay.
You good?
Yeah.
So you're gonna go perpendicular to the lamina, perpendicular to the blanched line, north, south, east, west.
Like so?
I feel like your finger keeps moving off here. Where's your SP right there?
Yeah.
Yeah, right there.
On it. Yeah.
Okay, so I think you need to blanch a little bit more out because I feel like you're not making yourself enough space. He's a nice big broad dude, so you got room there. It's not like doing it on Tara. There you go, that's better. Now from there, right there, and aim for the lamina.
Okay.
Let's see it.
All right.
Perpendicular to the line is gonna be like that. See the difference? The slope is different. See how your finger's sloping down?
Yeah.
So the blanch line is going to be more like that. Or not the blanch line, the perpendicular angle.
All right, so my finger's still on SP.
Uh-huh.
And then the blanch line's gonna be, and I don't want to go too medial.
That's perfect.
Okay.
So compress that damn tube. There you go. Tap it hard. And then continue. So your angle of your needle got lost a little, so find it again. You need to go perpendicular to that line. So perpendicular is more like that.
Right there.
Okay, pause, don't move, because I need to give you better coaching. See how your needle is above where your blanch line actually is?
Yeah.
You can't really feel what's there. So you need to reinsert the needle to where you can feel. Like if I can teach you guys anything, it's only ever put the needle where you can feel where you're putting the needle. And so when you tapped in above where your blanch line actually is, so I would redo that needle. It's not unsafe, you're not in an unsafe area, but the truth is you don't really know that. Like I can tell by looking at it, it's not unsafe, but you can't tell, and that's what's really most important.
Right. Okay.
You guys good over there?
I have to get my left hand stronger. Jeez.
There you go, you got it, that's good. So pull down, not all the way down, but like compress and then stabilize, that's perfect. Spread that a little bit more. Now that's perfect. Now tap right there, and you're gonna go, and all these reps, so perpendicular line is gonna go like this. Here,
So it was lower. I put the needle in a
here,
little
I think if I show, I'm gonna show you something. Yeah, give your arm a break. I'm gonna show you something. Kevin, you good? Building grip strength in here.
Seriously.
So let's use the tube this way. So here's his SP. If we do the tube like this, your perpendicular, see how his articular pillar is anterior. So the perpendicular line is like this. You see what I mean?
Yeah.
Or if I were to do it this way, you good there, bud? My man hands are okay for you? So if I do this, perpendicular line is that. Does that make sense?
Yeah.
Like my finger is the needle going like that. You were kind of coming in not sure if you should come this way.
Right.
You need to visualize that line better. So if this is SP and this is articular pillar, see my blanched line is pretty obvious
Yeah.
that I'm gonna go like that.
Yeah.
If you're not sure, the tube would look like that. The perpendicular line is gonna be like that.
Yeah.
Does that make sense?
It does.
Okay, try it again. It
doesn't
just takes
hurt.
reps. No, I know, don't worry about it. It just takes reps. It's like, that's, you know, that's why we're here. Exactly, that's exactly right. Beautiful, beautiful. That's perfect.
Okay, so I see that line.
That's the
there.
line. So what's perpendicular to that line? How do you make your needle perpendicular to that?
Right there.
Close.
No. So
But just make sure you're putting it between your palpation line. You are. It looks good.
Yeah.
That's it. You're gonna get it. Compress that tube like you mean it. Tap that needle like you mean it.
I was like, this seems fishy.
Yep.
Okay.
And then that's the angle.
Know something, but
You might have come in a little too close to SP, to be honest. But your perpendicular line is good. Did you get there? I mean, you
like stuck.
Yeah, bring it out. Remember, he's a broad guy too, so his SP, remember in the cervical spine, the SPs aren't quite as like, they're a little bit like, they're a little bit double bumped.
Yeah.
They're kind of double bumped. So,
So for him, I can go out like just wider.
yeah, a little wider, and just remember that like what you feel is gonna be broader on the top of the SP. It's a little bit. Try to feel, there you go. That's the articular pillar on him.
Yeah.
So you see how much room you have?
Yeah.
You were just too close to SP again. That's why.
Yeah, I
So-
can feel that under my
Yeah,
finger.
do it one more time. You're getting it. You know how like when we do iliopsoas from the back,
Yeah.
we like tap, like if this is spinous process and this is transverse process, we insert and then we like walk it to the end until we go. That's what I was doing on you.
Oh, okay.
Because but I was here, let me just go where you are real quick. So if we're here, SP, and then I blanch that line, and let's say I tap, I know it's hard to see
You
with
keeping
her
your
hair.
finger on SP here?
Always,
Okay.
yeah. And then this guy is like my what I feel is the end of the transverse process,
Gotcha.
right? And then, so if I want a perpendicular to this line, it's gonna be like that, right?
Okay.
So I'm gonna compress that tube like I mean it, I'm gonna tap that needle like I mean it, and then I'm gonna, a lot of times when you let go, you gotta refine that angle, right?
Yeah.
So I'm gonna go into that angle that I first found, which is right there. On you, I could feel the tightness so much that I was like, wow, she's tight. So I actually ended up pulling it and sliding moving it lateral to get more of the spinal erectors as they across to the articular pillar. Like that's
Gotcha.
the very end of her articular pillar there. She could either slide it like I'm ever so slightly moving my base hand so that I'm coming out and then sliding my base hand and going back in. Or you could just like keep your hand here and start redirecting laterally a little bit.
Gotcha.
And just every time feeling the bony landmark at the end. But yeah, that's gonna help you get, the nice thing about that is you're not only gonna get multifidi, but you'll come out towards like, at like 3, 4, 5, you're gonna get, if you come all the way to the sides, you're gonna get parts of like levator scap where it attached there,
Okay.
maybe
Yeah.
parts of scalene, but mostly levator scap, which is great. And you'll get like, semispinalis capitis comes up this way, so you'll get elements of that. So you just get different muscles as you come across
Gotcha.
the lamina.
Okay.
Yeah, cool. Let me know.
Sorry, one more question.
Yeah.
Is your finger on the spinous process or next to it?
Yeah, so when I'm doing the left side, can I use your finger as let's go like this. Okay? So your head's up here. So, and I'm over here on your right side. So when I do the left side, I have pointer finger on spinous process, and then I blanch over.
So it's on top.
When I go right side, middle finger, blanch. So it's boom, boom.
Okay.
Makes sense?
It does.
Okay.
That's awesome.
Cool.
Thank you.
Yeah. How'd it go? Good?
Yeah.
Great.
Ready?
Yeah.
Poke me with a needle. Oh, I don't need glasses though.
Yeah, you don't need to say.
You don't need to see. Trash can, you got it?
Oh, does it feel the same? I know it's not because it's silly.
What?
You forget that part.
No swatch? Oh, yeah. Sorry. Yeah, I'll just give a little face wipe for you guys real quick. You're welcome.
It's not gonna be good.
Yeah, that's fine.
You're good. Just chemicals.
It's okay.
Kind of. It's fine, like, not the worst. Better than, that's true, but. Let me know when you're ready, Kev. How's that feel, Tara?
Getting the hang of this.
Yes, you are. Looks phenomenal. Yeah, you're hitting it faster, right?
Yeah.
Doesn't it feel good?
Even Dave's like, now when the needle goes in, it doesn't hurt.
Isn't it amazing?
I'm like, oh good, I'll get better. He's
I
like,
know.
"You are."
It's true.
He's my only test dummy, really, so.
I know.
He
That's
bought
how
he
Matt.
He bought a table and everything.
Oh, that's
Can
awesome.
you, when you went on his golf trip, he's like, can you do my shoulder again? And I'm like, I can.
Yes.
Sarah, if you would have practiced ever, I was so.
I know.
Jess is ready.
I know. It's hard though because you live
Sorry.
Even at home. So you want to practice? I'm like, no, it's not the thing.
Sorry, Dane.
Good.
Big head in the way.
I always do wraparound. It's just the way that
No, it's good. So yeah, do you want to play with this way? A little
Yeah.
bit? I end up having to come like this way a little bit, because see
Okay.
how right now your second finger is like lower than you
Oh,
kind of
really?
want it to be,
A little more
yeah, a little,
orthogonal.
so
Okay.
yeah, that looks way better. Yeah, now you're perfect. And then you could probably, that's perfect. Yep, come out a little bit because you want to give yourself room to get in there.
Yeah.
And then you're going to come just halfway between the two, A and B.
And when you're saying perpendicular, because I didn't see your angle.
So see that blanched line? That blanched line right there?
Yeah.
You're going to go perpendicular to that. That's
Okay.
literally, so like, yeah, so that angle looks perfect.
Those
That's
dropping
pretty
straight.
much where you're heading. That's great. Yep, so compress the tube, and then DIP tap will feel better to them.
Okay.
And then head straight in. That looks perfect.
Okay.
You don't have to be so medial though.
I do.
Like right there, like
Oh, okay.
perpendicular to that line.
So just pretty much straight.
Like right there.
Yeah.
Just the same way you tap it in is that perpendicular line.
Okay, Abby?
You're there. So easy, right? See, I think the medial, like when people were taught that medial way, and I watched this when I taught for years and years, it's so inconsistent, because if you think about, you want to take that out and I'll tell you both. If you think about, like, if you're tapping, if this is spinous process and this is articular pillar,
Yeah.
and you're like, say you tap in here and you're going medial and you're looking for lamina, do you want to look up, Abby? Like if you tap in out here and you're going medial, that's going to be a very different distance than if you like tap here. Like you're not, first of all, you're going to get to the side of the spinous process more so than the lamina, which is where multifidus lives, right? But also you end up missing your mark, especially
Bone more than you hit muscle.
oftentimes if you go too far medial, yeah, you don't get to the multifida, you hit the medial of the spine, the medial side of the spinous process.
That's what happened. I hit the bone
Who? On who?
on him like too early.
Exactly, on the right side.
felt the
Also,
bone and I
because
didn't
the spinous process is bifurcated on the cervical spine. So that's partly why, because you were probably palpating on the, like maybe the medial side of the SP and not remembering that it's like kind of like that. So you were kind of here and you went in right there. That's why you went so fat, right?
Yep.
But it wasn't that you were too medial, it was that you were too close to the spinous process on that point.
Okay.
But what I'm saying is when people learn the way where they're like here and then they're going sharply medial, they're not getting to lamina. The distance varies so much, it doesn't train the brain onto the three-dimensional anatomy as well as if you go perpendicular every time,
Okay.
you know?
So do you ever redirect
Sure.
fault medial? Okay.
I don't think medial. You want to think about, you don't want to think medial. Medial to what? You want to think, hit that lamina. So don't think, I would avoid thinking anterior medial or inferior, like I would kind of avoid that. I would think this finger is on spinous process, this finger is on transverse process. I know that between the two is lamina. So if I keep my landmarks where telling my brain, my somatosensory cortex where your bony landmarks are, then I'm going to hit it. And I don't have to think medial, you know what I mean? But I might redirect it. I might just say, I'm not on it, I feel like I should be. Let me try a different direct. Like, let me try just move it ever so slightly, whatever direction my brain feels like it should be.
Okay.
Instead of thinking medial or whatever, you know?
Gotcha.
Just feel. Yeah,
Carry that rule down to lumbar as well?
for sure.
Okay.
Yeah.
Okay.
Yeah. And my point is, the more reps you guys get with this, the better you'll be at that learning curve of feeling rather than just kind of guessing and using like using a concept rather than actually feeling.
Right.
You know? Cool.
Okay.
Do you want more practice with that? You kind of nailed
I
it.
just wanted to see it CT.
Yeah, let's do it.
That.
And also and just do one where you feel the opposite, because it's
Yeah.
different when you do the second finger. So on that side, you'll do second finger. Yeah, great. And then.
Right.
That's great. And then, yes. Try to drop that down so you have better. I'm going to come on the other side so I can see you better. Looks great. And see, that blanched line shows you, it says stick me right there, and it shows you the perpendicular angle.
And then you just drop straight down.
Yeah, and you don't have to be that close. Like what I was saying to Abby is you don't have to be right next to your finger
Okay.
here, because this finger is on articular pillar essentially.
Right.
So you basically want to split A and B.
Somewhere there.
50%, yeah, like halfway,
And
and
then
then
go.
angle directly into that perpendicular angle, which is, you nailed it.
Gotcha. Okay.
Okay, perfect. All right, let's do the CT junction one, or whatever. Now CT junction on Abby, I'll be honest, I probably would do the wraparound,
Okay.
because you're gonna be able to lock it in better. And the angle is definitely a tricky one there. Like if we take a tube to C, it's gonna be a little bit of a tricky angle. It's gonna be like a scary angle because it's almost going inferior, right?
Right. So.
But when you have your fingers on, so I often on that on someone like Abby, I will definitely do the wraparound technique, is what I was saying, this one.
Okay.
Because I can lock in and see how here, if you come up here so you can see my blanched line. So my blanched line is showing me again that perpendicular angle,
Okay.
which is I remember when I first learned this, I was like, Jesus, it looks like it's going down.
Yeah.
That's the other reason the inferior medial thing doesn't work. Because it changes depending on how their spine position is.
Right. Okay.
So go ahead and do it if you want. Yeah, that's perfect.
Well, you
That's
just kinda-
perfect.
You just kind of hook on.
Yeah, just hook on, and then you're gonna go right there. Feel the lamina. Don't change your hand position. You had it.
Gotcha.
Did you move your? I feel like
might
you
have slipped.
moved it up. Yeah. So start over. So 2 fingers on the SP. Where come up and down so you can feel S. Are you settled on one SP?
Yeah,
Now
that's my
just
index.
walk it off. Don't drag the skin too much. Just
Okay.
kind of walk it off one finger breath. Compress first. Don't spread yet. Compress, then spread. Now you have that blanch.
Okay.
And then you're going to be boom, like that.
Gotcha.
And when you get nervous, you'll feel SP on the DIPs of your fingers, so it won't be scary, because you'll know right away that you're where you're supposed to be. Do you want to do one?
I guess just haven't done CT enough, but
Well, no, everybody. I mean, I would say that Abby's CT is a tough one, so I think that's.
is that the angle?
Let's
Sorry,
see.
my finger's in the way.
No, I shouldn't move my head. Yeah, that looks perfect. You want to do one?
Sure.
Good, guys? It's good for you to see the other ones too, right? Abby, you good?
Yeah, why is it tough?
It's just a sharp angle, it's a sharp angle down. Not tough, but scary. I would say scary for people, because, it's just nothing, you're perfect.
That's all you need to hear today.
Yeah, don't worry. Everybody's different. There you go. That's beautiful. Yeah, and I'll just feel, so is that SP? Yeah. Come back one more time. Let me see your whole process again. So go on SP. On top of SP. Good, and then just walk it off. Yeah, a little bit more. Now compress and spread. Yes, that's perfect. Don't spread too far. That's all you need.
Okay.
Right there. And then inside the blanch line, perpendicular.
Is that the angle?
Yep, and this one I usually go a little bit. I'd rather you err a little bit that way. Yep.
Okay.
Compress the tube. DIP tap. DIP tap. Bend
Dip.
this. Bend
Ow.
this. There you go. Can you? There you go. Tap hard. There it is. And then keep that angle. You got it. Keep that angle. It looks perfect.
You okay, Abby?
You're there. You're almost there.
Yep.
Perfect. Beautifully done. Great job, yeah. Felt seamless, right, Abby? Yeah, good job. Yeah, it's just like on that seat, like a lot of all the junk, to be honest, every juncture, CT junction, TL junction, lumbosacral junction isn't hard, but like CT and TL junction are hard.
Yeah.
TL junction's hard because the transverse processes at the TL junction are like minuscule. And this one's hard because on a lot of people, like your curves from your thoracic to your cervical spine transition is just a little rounded.
Okay.
And so the angle, it changes the perpendicular angle of the lamina, which is just scary when you go to feel it.
Okay.
Because it looks like when you're palpating that your needle's going like down more than it probably is. You know what I mean? Cool? Good, let's do some other stuff. So let's do, who wants to be rector spinae and suboccipital? Do you guys want to do suboccipitals or do you just want to see the difference? I feel like you can do them safely as long as you do certain like things to check yourself. Yeah? Okay, good.
You know, we differentiated oblique capitis inferior by itself, and then we learned.
Yeah,
rectus.
exactly. I wasn't, well, and so I was going to teach you guys I was actually going to teach you guys rectus capitis posterior major and minor.
Yeah, sure.
Like those.
That'd be great.
Like, I mean, we've taught OCI in here before. I probably don't, if we're going to do the other things, I probably don't have time to reteach OCI and rectus capitis posterior major and minor and rectors. So I would say either OCI review or rectus capitis posterior major minor, because they're very different techniques. So OCI is where we get the obliquus capitis inferior is where we get the muscle on C2. It's a great muscle. We might be able to do all three. Let's try, because all we have after that is the arm and the hip. Actually, you guys want to do both?
Yeah.
Sure.
Okay. Yeah, it'll be helpful. Okay, sold.
You want to do it on me? 'Cause
Yeah, let's do it. All right.
hair is helpful.
We'll do it here. What'd you say?
Lack of hair.
Yeah, it's so true.
You want shirt on, off? Do you care?
I don't care, actually. Let me just wipe that for him. I don't know, it's like that season. Just at least the face thing. All right. All right, so it's dry enough, right?
No, you're fine. I don't care.
All right, guys, so things to consider. We're gonna go through erector spinae on the occiput, right? We're going to go through obliquus capitis inferior, which we're going to get on the C2 lamina, essentially. And then we're going to get the true suboccipitals, so rectus capitis posterior major and minor basically on the more the inferior nuchal line down here. Things to consider: if you have someone with hyperlaxity, there's a very high incidence of a correlation of someone with hyperlaxity syndrome and Ehlers-Danlos syndrome and a Chiari malformation. So I would not, if you have somebody that's even hyperlax, I probably wouldn't do the suboccipitals because there's a potential that they have exposure there of the base of the brainstem, So don't want to mess that up, right? So if, like I said, Chiari malformation usually correlates to that. I don't think I've ever met a patient who's had a Chiari malformation and hasn't had hyperlaxity of some sort. So I think it's safe to say that that's a good trigger for you, okay? Otherwise, it's very safe. You just wanna make sure that their head has to be in the right position. So let's start with the easiest and then we'll go to the hardest, okay? So that's freshest in your mind. So for the erector spinae on the occiput, let me get the anatomy app real quick just so I can show you guys these. So remember the erector spinae, we're gonna catch them between, so we have, just again, orient yourself, the base of the skull, right? At the very base of the skull is inferior nuchal line. You come up and the next line you're gonna feel is superior nuchal line, okay? So the erector spinae essentially attach just below the superior nuchal line. So what we're gonna get is we're gonna get them between the inferior and superior nuchal lines. That's how you're gonna get those, okay? As I said, when you do those, you're gonna, actually I'll show you guys SOC too, superior obliquus capitis. That's another like suboccipital one we can get that's safe. But when you're gonna do those, a couple things are really important, as with all needles, all needle approaches, is again, palpate so you know where you are in space. And then needle angle is gonna be really important. You're always gonna be perpendicular to how your fingers are telling you like where you're palpating. So for instance, if here's superior nuchal line, here's inferior nuchal line, and I'm palpating across these top bands, compress spread, my perpendicular line is gonna be directly into where my fingers are telling me that muscle and that bone is. And I can feel bony landmark right underneath, so I know I'm safe, okay? If you don't feel the bony landmark, you're not safe. We're gonna use that same rule all around, because the bone is what keeps us safe here. So let's swab him first. And then actually, I'll have you lift up and I'll show you the anatomy real quick. Upper trapezius, then we have semispinalis capitis. And then the next body is gonna be the back of SCM. Okay, if I remove SCM, you'll see that under that is splenius capitis. And then under that is going to be superior obliquus capitis, essentially. So one of the things we can do is get superior obliquus capitis on on the mastoid process here, under SCM and under splenius capitis, if that makes sense, okay? I'm going to remove more of these so we can talk about when we go to the other muscles. So let's remove semispinalis capitis. And then under here, these are, so we already talked about obliquus capitis superior, SOC as I call it. Here's rectus capitis posterior major. So we can get these guys on, this is the inferior nuchal line, right? If I remove the muscles, whoops, you'll see, the foramen magnum is deep to that and there's thick tissue, but as long as you stay on the outer, like I'll talk to you through it, on the outer half from midline, you're gonna be safe, but always the safest thing is to feel the bone underneath your fingers. And then you're always gonna aim for the bone. If you don't feel the bone, that's a problem. Okay, so you need to feel the bone with both fingers. Here it is. You guys see that? So C2 to C1 transverse process. So we're gonna angle that needle onto the C2 lamina. I'll actually start on the top of the head like this, like I'll start this way, because I can easily pull up against the occiput and feel everything I need to feel. So remember, like I said with the neck, always, I do, especially with this one, make sure they're in slight extension, because that'll just tuck that foramen magnum under C2, essentially, and make you less likely to go to the wrong zone, okay? Can you see okay if I put this here? We already swabbed him. I'm gonna get my needle ready so that I can, now I would say I'm gonna grab a 40 for him just because he's muscular. I'm probably not gonna need a 40. I'll do a single use actually. But I'd rather have 40 than be short, I'd rather have more than be too short. 50 is way too big. All right, so same thing as before. C2 is always gonna be my first landmark, and then occiput, right? C2, occiput, C2, occiput. Find it multiple times so you can build that in your brain and your comfort with where you are in three-dimensional space. Then I'm gonna, if I want to, I can come around and start palpating the erector spinae. I'm on inferior nuchal line here, right? Because I'm basically C2, occiput, and the base of the occiput is that inferior nuchal line. I can kind of feel those muscles attaching there and comb across. Remember that superficial to the suboccipitals are the upper trapezius. So let's go inferior nuchal line, let's come superior or cranial midway through, right? Here's the superior nuchal line. I want to find that zone in between inferior nuchal line and superior nuchal line for the spinal erectors on the occiput. And then I can orient myself from midline. I have upper trapezius. Remember the greater occipital nerve's going to come through there, so you may get sparkles there. It's no big deal if you do. You just, just be cool with it. Then you're going to come across that. The next band is going to be semispinalis capitis. And then after that, oh, that's a good one on you. That's likely SCM. And then under SCM is how we're going to get SOC. Okay? SOC we're gonna hook onto the masseter back here. But let's start with the easier ones. So in between inferior and superior nuchal line, I can do upper trapezius right here. I'm palpating across the fibers. My fingers are gonna compress and spread. Do I feel bone underneath my fingers? Yes, I do. Am I above the inferior nuchal line? Yes, I am. Am I slightly below the superior nuchal line? Yes, I am. I'm safe to go. I'm gonna compress and spread. I still have that blanch line. That blanch line will save your life. That blanch line is like, if I can teach you anything, it's get familiar with what perpendicular to the blanch line is all the time. Compress, spread, tap that tube, tap the needle DIP, aim perpendicular to the blanch line, and now I'm on the occiput. And that's it. If I want, I can slide that tissue. Let me know if you get sparkly. You'll tell me, or you did?
You're good.
Okay.
Yeah, a little bit there, not much.
And then so I can slide across that, or I can leave it in. If I'm gonna leave it in and stim, remember to push it against the bone so that that recoil doesn't pull it out with it. Okay? Super simple. You can do that all the way across. Very safe in between the inferior and superior nuchal lines. Very, very safe. And very effective. So if you're not ready for this stuff, if you feel a little nervous and I'm not right there with you and you want another review of it, by all means, like, follow your instincts. You always want to be 100% safe and comfortable. And you can get a lot of bang for your buck with this one. Let's go through the others though. So the next one we're gonna do, I'm gonna do everything I can at the top of the head first, and then we'll end with OCI. So that was spinal erectors on the occiput. The next one I wanna teach you guys is, let's do like rectus capitis posterior, right? So, oh, and you're tight there, my boy. So if I wanna feel C2 and then comb up and feel the base of the occiput, right? So I feel some bands here. Remember how I showed you how essentially, like, if here's mastoid process and here's the midsection of the occiput, that's our real estate, right? From halfway between A and B here and over is pretty darn safe. All of it's safe if you're on the occiput. But like, you're way away from foramen magnum if you want to go on this lateral portion here, right? So if you want, you can come up to the base of the skull, lock in, like right there is a nice little band on him. I'm about 50% through, so I'm safe there. Compress, so I'm gonna pull that up so I'm away from the base, like essentially away from the space at the base of the occiput. Pull that tissue onto the occiput. Compress, spread, and then again, I'm going right into where I feel the bone beneath my fingers. I have that muscle, I'm on bone now. I have that muscle between my fingers, so my fingers are in real time telling me every time what I need to feel. You okay? Okay. And then same thing, if I want, I can slide it over a little bit because I feel bone every time and I know I'm safe. So that's essentially inferior nuchal line, which is gonna get some of those at least rectus capitis posterior major on that side, okay? SOC is super easy, if you will. You do have like the lesser auricular nerve near there. Again, it's okay, they're small nerves, they're gonna feel sparkle. You just like, they'll be like, oh, I felt that in my ear, it's a little sparkly. It's okay, just don't pepper it, just kind of move away from it and take it slow when you're going in those regions, but I'll show you one of those. So same thing, palpate for occiput. SCM is like obviously gonna be kind of bulky here. See how that's all SCM. SCM's such a mother load. But what I'm suggesting is you can actually, I like to pin SCM to the masseter, right? And even like, so transverse process of C1 is right under that masseter, right? Or masseter, mastoid process, sorry. So pin SCM to the mastoid process. You can use your finger to orient yourself. Yep, I feel transverse process of C1 right there. Now I'm gonna take my finger back and pin both onto the back of the mastoid process again. And then I'm literally gonna come up into the mastoid process. It's right there, it's deep on it because he's got a nice meaty SCM to get SOC. And this is a great headache muscle, okay? So superior obliquus capitis, right on the mastoid process, or right, but it does have to be on the medial side of mastoid process, right? Because of how it attaches from the cervical spine. Cool? Good, let's do one more. Let's do OCI. How you hanging? Good. Feeling okay? Good. So OCI, I do this in the same way that I do the multifidi that I showed you guys. Now, I will say, I like to get up close with this, and I talked to you guys through this a little bit with the multifidi, but like if you notice, I like lean into them with this one. You really want, remember the furniture in the room analogy? Like you need to feel as much of the furniture in the dark room as you can so you don't bump your shin on the side of the bed, right? So as close as you can to them, rest your arm on them. You need all that points of contact just to give yourself confidence that where you are is where you think you are. So I'm probably gonna need a 50 on this one, at least. And remember, we're gonna catch this. We're gonna catch this OCI, obliquus capitis inferior, goes from the spinous process of C2, so here's his occiput, C2, right, up to the transverse process of C1. So remember how when you were doing multifidi, I think it was you, one of you, and your hand was like down here, and I was like, okay, maybe it was you, Kevin, actually, and I was like, okay, you need to be right next, right, like lateral, so that you're on the same segment. On this one, you don't want to be on the same segment, because you want to catch obliquus capitis inferior. It goes from C1 to C2. So we actually need to palpate the landmarks like this. So my pointer finger is on C2. I'm gonna blanch, compress, and spread all the way up till I feel C1 right there. And then my needle direction on this one has to be, this is why I said earlier, don't think medial, Kevin, right? I was like, think where's the lamina? I need to hit the lamina of C2. So if I'm splitting that, I'm aiming for the lamina. I didn't feel it where I thought I should feel it, so I'm gonna do it again. I'm aiming for that lamina of C2. It's essentially, if you do wanna think in angles, I'm gonna raise this up a little so I can get a little closer. If you do wanna think in angles, it's essentially like a 45-degree angle towards C2, essentially. So we're here on top of C2, compress and spread to C1. I'm gonna split the distance between A and B like I do, and then aim back, kind of angling towards C2 lamina. And I don't know why I'm not getting it, hold on. What is that noise? Sure does. Here we go. Here. There it is. So Kevin, remember how you were like, do you ever redirect? Like, it is true, it takes time. Like I knew when I was going in, I wasn't feeling your lamina at first. But it wasn't like, oh, I need to go more medial. It was like, oh, where does my needle need to go to hit the lamina? And it happened to be more medial. Do you know what I'm saying? Did you guys see that? So let's do another one of those on the other side, just to give you guys more reps, since the first two were hard to get for you. So here, so same thing, like now as with the other multifidi, I'll do middle finger on C2, spinous process, compress, spread to C1, and then split it, and then I'm angling on to C2. Same thing, I don't feel it right away. This one's definitely a little harder to get on people. You okay? I don't feel it yet. I might give you a bruise. Let's do one more.
I know when we learned at JJ that they said like you essentially aim for the opposite eye.
Not.
Was kind of how their direction was with it.
Not on this one.
Oh, that's what I thought.
I wouldn't, because you need to angle down. The eye would be upward. So this one in particular, so OCI, so this one in particular, you do have to angle down, because if you angle up, you're going towards foramen magnum actually. So, but SOC, you're aiming towards that eye, and like rectus capitis posterior major minor, you're essentially aiming towards the eye, and even this one you're aiming toward the eye, but OCI, you need to aim the opposite. Yeah, you need to aim towards your, really it's towards your finger.
Okay.
Like, there, now I'm there. Sometimes you just need to, like, it's not really towards your finger, but towards where your finger's telling you the lamina is, if that makes sense. Yeah, so now, I mean, that was much easier. I don't know. It's like everything, sometimes you just need like a break. Like you just need to stop and reset. So I think it's always good when you guys see that.